Great, thank you. Thank you for joining us. I'm just going to start. I'm Dr. Matthew Sharpe. I'm the owner and surgeon founder of SharpeVision MODERN LASIK and Lens, and I just am thrilled to be doing this, thrilled to do what we do, and wanted to talk to you a little bit about the implantable contact lens, which is being called, sort of for marketing reasons and everything, the EVO or evolution of the ICL. And so I'll get into why that is and what's changed with it too. But I'll start. So I'm going to just start the slideshow here. So let me see if I think you can see. Can you see the screen there? Yeah, I mean, I'm sorry, you're seeing the let's talk about it there. Okay, so we'll talk about it, the implantable contact lens, or ICL, and what it is, what the good, the bad, the ugly with it, and how it might be able to help you get out of glasses. So we'll talk about it. So the problem is nearsightedness. And one of the specific problems that the EVO ICL can solve is that when we got into very high degrees of prescription or somebody with thinner corneas, we didn't have a solution for them, and we said, you're not a candidate. And that still may be the case, that you're not a candidate for laser vision correction, but you may be a candidate for the EVO lens too. So we can treat extreme nearsightedness with it very accurately and very effectively. So it's fantastic, and that's the solution part. And I'll get into the benefits, what it does that LASIK doesn't, and vice versa, what LASIK can do that the EVO ICL can't do, the side effects, potential issues with it, risks, and then take questions. So I'm just going to go ahead and start on the problem. So these are the main types of refractive problems that we have. That's nearsightedness. And that's what most people that we see are nearsighted. And farsighted is just the opposite, where your eyes don't have enough focusing power with farsightedness. They have too much focusing power with nearsightedness. Astigmatism, a lot of people don't understand what astigmatism is. And it's just, suffice it to say that we can fix it with either laser vision correction or the EVO ICL. We can fix astigmatism. And what that is where, and I always use this imagery of, if you took a tennis ball, you cut it in half, that would be a spherical eye. But if you squeeze the sides of that tennis ball, that would create the shape of astigmatism. So we can fix that with a variety of techniques. Now, presbyopia, the bottom thing, there's an asterisk beside that, because that's not technically a refractive error. That is just something that happens to everybody right about age 45, where you have to kind of make a choice. You can either see distance or you can see near, but you can't see both distance and near after about the age of 45 is when it starts for most people. And then by 55, the lens of our eye becomes completely inflexible. So again, you have to choose distance or near, unless, and we won't get into this too much today, unless we remove that inflexible lens and replace it with an artificial lens. So there potentially are solutions for presbyopia that we can talk to you about here at your consultation too. So I'm going to go, presbyopia is really important for those near and intermediate tasks. So that's where it becomes really a nuisance. And I always talk to my patients about that, say, think how many times you pull out your phone, and if you had to throw on glasses every time you wanted to see your phone, boy, that would be a pain in the butt. I mean, I must pull out my phone. If I'm not at the office, I must pull it out 50 to 100 times a day. So I'm guessing most people do. So near task, very difficult to function without reading glasses. So let's see if I can't see that screen. Check anyway. So ICL, we're going to talk mostly about the ICL, or implantable contact lens thing. It's not new. I just saw maybe a month ago some colleagues that are in Argentina. They showed video from 1994 where they had the ICL, and it was almost the same model. It's changed in a few ways, but they've been putting it in for nearly 30 years in some countries outside the US. So it's not new. And this is just kind of a list. 1997, it was being put in the CE mark refers to the European version, basically, of the FDA. So they got approval for if you didn't have astigmatism. 5 years later, the CE mark for toric, which means if you do have astigmatism. So that was 20 years ago that they had the toric. And then in the US, we got approval for the ICL, again, where if you didn't have astigmatism. So that was fairly limited because most people do have some degree of astigmatism. And then in 2011, they got basically the same CE mark, the FDA equivalent in Europe for what they were originally calling the Centraflow, but then they changed the name to the EVO. So the EVO that we have now finally in the United States as of 2022 has been available outside the US for more than 10 or more years in most countries. So that's important because anything that's brand new, I personally also have some reticence to suggest it because there's always some issues and problems that we work out over time. So the EVO ICL has been implanted in about 2 million eyes around the world, and it's gaining acceptance now in the US much more so, and I'll get into why. It's easier to do the EVO ICL than it was for the previous model lens. So in 2018, we finally got the toric approval here in the United States after many years of the FDA dragging its feet a little bit on that. So that allowed us to put the ICL in someone's eyes and not have to correct the astigmatism later. I was personally doing the astigmatism about a month or more after with LASIK. So if somebody came in highly nearsighted, they had astigmatism, we would get rid of the nearsightedness. We had to do a separate procedure for the astigmatism. So kind of a pain for patients. And then finally in the United States, just earlier this year, I think it was mid-March, we got the approval for the EVO lens. So the EVO lens allows us to eliminate one pretty painful step of creating a laser hole in your eye. And I'll get back to that, what the EVO solves an issue that we didn't have previously. So here we're just looking at milestones. So LASIK and PRK were done in the United States. The first ones were done in 1995, and then we got LASIK approval a couple years after that. And then the numbers have declined just a little bit in terms of percentage of recommendation, because for our patients that were highly nearsighted, we no longer had to push the limits of the laser vision correction to get them seeing clearly without glasses. We were doing the ICL. So the ICL has made us it's allowed us to recommend something that, again, is a little safer and easier and more effective in the highly nearsighted patients than perhaps LASIK and PRK are. And then we also, in the past 10 plus years, have been doing a procedure more and more called RLE, and RLE stands for refractive lens exchange. So that generally is when you hit the older milestone in your 50s, 60s and above, because we can replace your natural lens, put in an artificial lens that not only corrects your nearsightedness, but it corrects your reading glasses too. So that becomes an issue and more of a recommendation for our a little bit older patients to recommend potentially the RLE. So circling the RLE or the ICL there, that's mostly what we're going to be talking about. And these are just a sampling of articles from the Japanese Journal of Ophthalmology, which is the main journal of ophthalmology, and how, and we know this, we all know this, I know this, I was a -8, had a -8 glasses when I was a kid and got LASIK in 1998. So 25 years ago, I had LASIK. It's life-changing. And anyone who has extreme nearsightedness knows that you can't go to the bathroom without your glasses on. I mean, you can. Walking around, I had a woman one time say she felt safer. And I said, well, why do you feel safer after LASIK? And she said, my kids, if they have a problem in the middle of the night, and before she got LASIK, she'd have to stumble to the kids, couldn't see them, it was dark. Now with LASIK, she can just go straight to her kids. And man, that just makes me feel great to be able to change somebody's life in that way, and many, many other stories like that. So it's an amazing profession to be in, and it's just very rewarding to do. So is it a good fit for me? So moderate to severe nearsightedness is generally where we start to recommend the EVO ICL. So there's a few things that we would measure, and we would measure all this in your free comprehensive exam at SharpeVision. So we'll get to how to schedule that online. You can schedule that online, but there are some things. So there are certain people who don't have enough nearsightedness to recommend the ICL. And for those patients, we typically are going to recommend the PRK or LASIK, especially for our young patients. And then it can treat extreme nearsightedness. So if you've ever heard of Coke bottle glasses, that's what we can treat with the ICL. And so it'll treat up to -15, but also with up to 4 units or diopters of astigmatism. Surprisingly, sometimes people even have astigmatism or nearsightedness outside these ranges. We potentially could still do the procedure and then potentially do LASIK to treat any additional astigmatism or nearsightedness. So we can treat quite a bit of nearsightedness that almost, and this allows us to treat almost anybody of any age or prescription. There's also anatomical limit. There's a space behind your cornea, which is the clear window of your eye, and in front of your natural lens. So there has to be enough room in there to put the lens in. And that's probably 90% of the time there is enough room. But again, one of those things that we would measure at your exam. So this is just Joe Jonas is a spokesperson now for the Star Surgical Company, the maker of the EVO ICL, and he had this done probably 3-4 months ago, and is just raving about it and how it's changed his life on stage and makes him a better performer and all kinds of things. So it's fun to have him talking it up too. But we'll look at everything when you come in for your exam, the surface of your eyes. And I just about an hour ago had a patient come in and he said, well, what about my dry eyes if I have the EVO ICL? I said, it won't change that, because with LASIK and PRK, almost everybody will have some degree of dryness. It does get better, but with the EVO ICL, that's just not an issue because we're not disturbing that surface of your eye at all with the EVO ICL. And so people with dry eyes, and I remember a young woman in her 24 who'd had dry eyes from a medical condition. We put the EVO ICL in, and then she no longer had to wear the contacts, which were exacerbating her dry eyes. One of my happiest patients doing that too. So that's always fun. And then the same patient an hour ago said, well, what about my corneal thickness? I said, that's not an issue with the EVO ICL. And so we can just don't even have to consider that, because we're not removing any tissue the way we do with the LASIK and PRK. The laser vision correction does take some of the corneal tissue by shaping your cornea. And then he also said, well, what about the curvature of my eye? I said, again, doesn't matter because we're not changing it. So it allows us to put that in there without removing any tissue. So what is an ICL? This little diagram in the bottom left corner is basically what it looks like. It comes in 4 different sizes or diameters. It comes in, so the total number of possibilities of different prescriptions and diameters and axis of the astigmatism is something around 6,500 different potential lenses. So when we do an exam for the ICL, I would measure again without any drops in your eyes, and we'll measure your eye so that we get the perfect lens for your eye. And 99.9% of people said they would have the EVO lens done again. This very happy patients, and again, very nearsighted in general. So it's pretty amazing thing for them too. Now, so the EVO, there's a couple things that change. So it's sort of like version 2.0 of the ICL. The previous model did not have holes in the lens that allow fluid to flow through. So in our eye, there's always fluid flowing from back to front, And with the previous model, we had to make a tiny laser hole in your iris, in the colored part of your eye. So it was another visit. It hurt. The drops we had to give you could make you nauseated and give you a headache. And so that has been totally eliminated, because rather than putting the hole in your eye, we put the hole in the lens. So again, something that they've had outside the United States for over 10 years. And we're just delighted that we finally got the approval here in the United States. So it eliminates the need for that, what's called the laser peripheral iridotomy. And it's so nice not to do that. So it also lowers the risk of pupillary block, because your pupil, the fluid flows through your pupil. That's the hole in the black hole in the center of your eye. Fluid flows through there all the time. And so this way the lens has a hole in it, so the fluid flows through that hole. It doesn't create the blockage of fluid the way it potentially could with the previous model. And our colleagues outside the United States say they just have never seen cataract develop from this lens. And so that's something that was a tiny risk before. I think that risk now is, I know it's not zero, but very, very low risk of that happening. And we'll all eventually develop a cataract, but it should be in your 60s, 70s, and older is typical. Although highly nearsighted people sometimes develop a cataract younger than the average person would too. So it just makes it easier for our patients in a lot of ways. The other thing that I didn't mention in that slide was the EVO lens. The optic is slightly bigger. It also has slightly better marks for the astigmatism, so it makes my job orienting the lens in your eye just a little easier too. So it's really a big improvement over what we had before. And the advantages of it are that we keep your crystalline lens, that is your natural lens. We're not removing your cornea, we're not removing your natural lens, we're just adding it in there like the Hubble Space Telescope. We're adding a corrective lens on top of what's already there. So again, no dry eyes. I've never seen that. I've only seen, if somebody has dry eyes and contact lens related irritation in their eyes, they actually feel better after the EVO ICL because they don't have that contact sitting on their eye. It is removable. Now, I haven't yet removed one because somebody was unhappy with it. We have had to, on a couple of occasions, exchange them if the lens was too big or too small. That's probably about 1 in 100 risk of that, and easy enough to do, but we hope not to need to do that. Rapid visual recovery. So typically we've got, the 2 laser vision correction procedures. PRK, one of the disadvantages is it takes longer to get that vision recovery. LASIK is very quick, but it hurts for about 4 or 5 hours. You get burning and irritation. But generally the next day with LASIK, you're seeing not perfect, but you may see 20/20 or 20/15, which is even better, but typically a little foggy. With the EVO ICL, I would say there's no pain post-operatively. You'll feel maybe like your eyes are dry, but no pain. And with the EVO ICL, it's about the same as LASIK, where it's not 100%, but our patients very frequently are 20/20 or 20/15. They'll say, yeah, there's still a little fogginess around lights, but very typically they'll see 20/20 or better on post-operative day 1. That's the next day. So pretty amazing. And ectasia, so it says no risk of ectasia. That's where the lens or the cornea of our eye can stretch or change over time. We always worry about it with LASIK. I find it's very rare with LASIK also, as long as we screen for that ectasia or that weak spot. But there's no risk of the ICL causing ectasia because, again, we're not removing any tissue. We're not weakening your cornea in any way. And as far as future cataract surgery, with the LASIK, we need to figure in the change in the shape of your eye with LASIK. So when you have cataract surgery, the lens calculations for the artificial lens are not changed with the EVO ICL, whereas they may be changed slightly with the LASIK. So not a big deal, nothing you'd have to worry about with the EVO ICL. I'm just going through all those. Let me do one more, click there. So what to expect? Because I think a couple reasons why people are reluctant to go through this and is fear of the procedure, fear of the unknown, and then the money too, because it's not cheap. I think it's a huge value though to it. It's extremely valuable to people doing it. So it's about, in my hands, it takes me about 8 minutes. It is really quick and painless. You feel nothing during it. I would say the two things that you may bother you during the procedure. One is the bright light. So it's very bright light, but after about a minute of that, or even less, your eye adapts to that bright light. So you can look at it and have no problem with that. But the brightness is uncomfortable initially, and you may feel a little pressure just right at the beginning. And I would talk you through that and tell you, okay, you're going to feel some pressure now. That usually lasts about 10 seconds. And as I said earlier, there's no postoperative pain, which even with LASIK, there's some postoperative irritation for a few hours. And again, there's no blood. We're operating on your cornea, which has no blood vessels in it, and no eye patch, nothing to do. And you typically could, as far as what you can do the next day, you'll see, that's what I say, it's not perfect on day one, a little foggy. I've had patients have trouble seeing things up close initially until the dilating drops wear off, but generally that's gone well within 24 hours, usually 12 hours. And you could do, I have no restrictions for my patients. They can go, use screens. You could go lift and work out and run, bicycle, any physical activity, stand on your head. You could go snowboarding. You could head a soccer ball. And that goes for LASIK too, that as long as you don't get poked in the eye, everything is going to be just fine with that too. So pretty easy to do. You're actually on the table usually under 30 minutes. It's about 8 minutes per eye plus a little time in between to get things ready for your second eye. So here's just a couple examples. Again, I saw a patient with very similar prescription just about an hour ago, 27-year-old active young woman. She's wearing glasses. Her contact lenses feel terrible, irritating her. And so her prescription, if you know on your contact lens box, there'll be little numbers. The minus means nearsighted, and it's basically like low, medium, high would be above 6, extreme would be above 10. So in this example, she's got almost extreme in both eyes. The second number, there's the astigmatism. So the average astigmatism we treat is 1. So this example, she's got more than, she's got 3 and 2. So moderately high, but we can treat up to -4 on the astigmatism too. So for this example, she's wearing mostly contacts, a little bit of glasses. I found that also with our patients generally do wear a mix of both. A lot of people since COVID are just going to all glasses too. So quality of vision, and quality of vision involves, academically, that involves things like loss of contrast sensitivity, which is sort of a washed out appearance, glare or halos, which is where if you saw a point of light, you'd have a halo around it, or starbursts. And I always say almost everybody will have some of that, regardless whether we do LASIK, PRK. Those are very similar in that respect. Contact lenses and glasses also have some glare. If your glasses are dirty, they get quite foggy too. Contact lens vision is very similar to what the quality of vision that you would get with the EVO ICL. That is, if you put in your contacts, especially if you're highly nearsighted, unfortunately, the physics of it make it so that it's usually pretty close, going to have some glare with contacts, glasses, LASIK, PRK, and again with the EVO lens. Very similar. No worse, no better. A couple things that could make it worse or blurrier is if your eyes are dry, they'll get a little blurrier. So we see that with LASIK, a little more dryness early on, and that gets better. And then the second is if we don't get the prescription perfectly. So that, as far as prescription getting absolutely perfect, with LASIK overall, it's about 2 out of 100 patients who have LASIK will need a touch-up or that enhancement in the early going, in the first 3 to 6 months. We typically do that. With the ICL, that can happen, and it's also probably in the less than 1% chance with the EVO ICL that we would have to do some laser touch-up afterwards or adjust it somehow. So infection, the risk of that, I have in this slide 1 in 10,000. I've never heard of anybody, even my colleagues, in terms of getting an infection after the EVO ICL or any other ICL for that matter. But with cataract surgery, it's about 1 in 10,000. So very rare in cataract surgery, but cataract surgery is more invasive, typically performed on older patients. So I think the risk of infection with the ICL, and it's quicker and a little easier, less involved, that the risk of infection is going to be way lower than that. And to put that into perspective, the risk of infection with wearing contact lenses is higher by a factor of about 10 compared to LASIK too. So LASIK infection rate's very low. The ICL rate is potentially even lower than that. It's so low that we don't even know what the risk is. It seems to be, it's so far is 0, but we know that's not true. You could have infection, but it's just very rare. So the other thing, the thing I worry about in the first 24 hours is pressure in your eye. We want to, so if you have the ICL, we would check the pressure before, after the procedure, about 2 hours after the procedure. We give pills and drops to take to just make sure the pressure stays normal for the first 24 hours. And then we always want to see you the next day. And I text all my patients to make sure that I check in with them. Let me know if you're having any nausea, vomiting, headaches, decreased vision. And so while that has happened in the past, that hasn't happened in quite some time. And actually PCO, that is referring to cataract surgery, so not an issue. So the side effects, glare halos, loss of contrast sensitivity, that sort of washed out appearance, that's always going to be there to some degree. And it gets better for probably several months, 3 to 6 months even. It will get better, but usually there will not be zero glare or halos, but again, very similar to what you experience with contact lenses. So I always ask my patients, say, go, before we do this implant, go out in dusk or darkness with your contacts in and take a look. Is there any glare? Sort of take a mental picture of what that glare would look like so that you can compare that to what you'd have after the ICL. And that's where most patients say, oh yeah, there's a little glare, but not bad. And so it can get better for quite some time, but the vast majority of the improvement will be in the first day, and then a little improvement for the first week, and then just subtle improvement for that after that for a month or more. So it's very and we virtually always do bilaterally, doing both eyes at the same time. So far I've only done once where we put an ICL in one eye and did LASIK on the other, because this particular patient had a big difference between their prescriptions in both eyes. And so that's just one person, but that person said that he did not notice any difference in glare or quality of vision between the two procedures, that they were both superb vision. So very, very happy about that. Joe Jonas again, what a looker. He's a good guy. So recap, the problem is nearsightedness, but specifically for the EVO ICL, it's high and extreme nearsightedness that we can now very safely, quickly treat. And so it solves that with the EVO ICL. Benefits, I can't even tell you how huge it is. I put the EVO ICL in my own son, who's 25 years old. So I had LASIK when I was 32, but we didn't have the ICL at that time. If I were to do it today, if I were 32 today, I would definitely do the EVO ICL, no question. I put the EVO ICL in my 25, now 26-year-old son, and he is over the moon thrilled. He had actually 2010 vision, which most people just can't even get, but his vision is superb. I've been out with him over I put it in April. So like if we were out doing stuff this past summer, I'd say, can you read that? And he could read stuff that I was like, wow, I can't believe you can read it. So pretty cool for somebody and he overwore his contacts. He was not a safe contact lens wearer. So risks, we talked about those, and that's what I want to talk about, the questions that you might have about it, because I'd love to be able to help anybody out there get out of glasses and contact lenses. If it's the EVO ICL, that's great. If it's LASIK or PRK, that's great. And if it's the RLE, that's also an amazing procedure where we do remove your natural lens and put in an artificial lens to allow you to see distance and near clearly, even if you're 60 or 70 years old. So we have different solutions depending on your age, your prescription, and now with a variety of techniques to help, we can help almost anybody get out of glasses or contact lenses. So give us a call. Locally here in Seattle, it's 425-451-2020, which is on our website, of course, or you can just go straight ahead and schedule your free comprehensive evaluation online at SharpeVision. It's Sharpe with an E -vision.com. So hope to be able to get some of you in here to help you out of glasses. But do we have any questions? Let's see if.
How many surgeries like this have you performed?
Oh, yeah. So, I was going to ask our rep how many so far, because since we have the EVO, we're #1 in Washington State. We were neck and neck as the top practice in the country. There's a couple other my colleagues that are doing a lot of these too. I'm guessing it's between 150 and 200 just since April. And then before that, we had done about 400 of the previous model, the Vision ICL, which is, the same technique, same everything. It just is easier now to do the EVO ICL. So it's a lot. Again, put them in my own son. I love them, and they're just has really helped a lot of people. So it's good.
Are there any medical conditions that you have that would prohibit you from having the surgery?
Not usually. As I said, the anatomy would be the anatomy and degree of nearsightedness would be the big things. There are a few things that would be like uncontrolled diabetes. So if your refractive error has changed significantly, that I've only seen that I'm aware of once in my 25-year career, almost 30 years now doing it. So that's something that's rare. Most people are going to know if you have diabetes, you're going to get it diagnosed and keep it controlled. I can't think of anything else. And there could be some other things like uncontrolled connective tissue disease, such as scleroderma or polyarteritis nodosa. These are autoimmune conditions that can affect the eye. Rheumatoid arthritis is one. Generally, that's going to be, again, something that you're quite ill if it's out of control. We've also treated people who have diabetes for sure, because if it's stable, there's no reason not to have it. And then people who've had rheumatoid arthritis, the condition that we're worried about with rheumatoid arthritis, or one of them, is dryness. And so again, with the EVO ICL, with the dryness not being an issue, we could potentially put in an EVO ICL in somebody who had even rheumatoid arthritis. So that's it for questions. Well, thank you for joining me tonight. And if that's all the questions, we'll end. And I recommend just coming in, getting information that's very specific to you on our website, that's sharpe-with-an-e-vision.com. We are a sponsor of Seattle Sounders. I treated one of their starters, Danny Leva, about a month ago. And it was just a thrill because he's one of the nicest young men. He's got a great future ahead of him. He was just interviewed on KGR by another spokesperson for us, Dick Fain, interviewed Danny Leva. So it's a lot of fun to be able to treat a professional athlete like that.
And one last question. Where do you currently do ICL?
Good question. Yeah, so we have a laser operating room that we do all of our laser procedures. And then one day a week, we convert it over into our sterile procedure operating room, and do it in our office. Now, that's a good question because we do them in there now. We would sedate you and everything sterile technique. But in about a month, we're going to be moving from our current location in Bellevue. We're on sort of the southeast side of 405 and 520. We're moving to the southwest side of 405 and 520 in about a month. So we're going to have our own ambulatory surgery center that will be Medicare certified, of course, Department of Health certified, and it's going to be state of the art. Very cool. We'll have everything. And that's, we can certainly do the ICL, the EVO ICL in there, but it's made for state of the art cataract surgery. So we're sort of overbuilt for ICL, but we can and will do those procedures in there. So we'll have a staff of RNs, and again, much more than we need, but really nice to have that new facility going in. It's going to be just spectacular. So I hope you'll see us in our old place before we move. But if we get you after, we should be moving in about 3 weeks to the new place, and then the operating room probably early January we'll have that fully functional. So pretty cool. That's it. All right. Thank you guys for joining. Hope you got something out of that, and we'll and you also can, if you have questions for me even before you come in, my email is drsharpe with an e at sharpe-vision.com. So hope to see you soon. Oh, there's pictures. I didn't know.